Good evening, everyone. I'm Dr. Kevin Smith, second year fellow in infectious disease at the University of South Florida. I'm going to talk to you tonight about the utility of nuclear medicine in the practice of infectious diseases. I chose this topic because I knew it was available. It's something we don't often use, but it does have utility, as hopefully I will show you. So start out with a little scenario to get you thinking here. 81-year-old male, history of AAA, status post-graft, recently returning from Africa, and fever for 6 weeks now. Exam being non-focal, some elevation in white blood cell count, inflammatory markers, cultures are all negative, pan-CT negative. So kind of a case of FUO at this point. What if you get a question like that? It asks you to pick one of these nuclear medicine studies. These are the ones that are commonly used in the practice of infectious diseases. So maybe you will learn something and have some kind of idea at the end of this talk. So here's an outline of kind of what I'm going to speak to you about. First, I'll give you a little introduction to nuclear medicine and the different radionuclides that are used, followed by the imaging techniques or tomography, SPECT, and PET scans. And then I'll give you present some data, some papers showing the utility of infectious nuclear medicine and infectious diseases. I'll specifically go over FUO, tuberculosis, prosthetic joint infection, diabetic foot, and chronic osteo. And then I'll hopefully try to summarize and give you some conclusions when you might consider using these studies. Alright, so nuclear medicine's an imaging technique that involves radioactive substances in the diagnosis of treatment diseases, is the basic definition. Nuclear medicine imaging is different from standard radiological imaging in that it shows pathophysiologic function, abnormal function prior to changes in anatomy picked up by standard imaging techniques. Most of the nuclear medicine scans survey the whole body, whereas traditional radiology is regional surveys. Nuclear medicine in general is more time consuming than traditional radiology, but with some of the newer radionuclides, these tests can be done in less than a day. So nuclear medicine is used in the diagnosis and in the treatment of some diseases. We may be, as internists, have more experience with the diagnostic tests of non-infectious diseases, such as like the adenosine scan for myocardial ischemia, the VQ scan for pulmonary embolism, the MAG3 scan for renal perfusion. We may have ordered more of those in the past, but it has its utility in infections, fever unknown origin, diabetic foot, osteomyelitis, prosthetic joint, cardiac device and pacemakers, ASCDs, even valve infections can be diagnosed by nuclear medicine techniques, pulmonary infection, opportunistic infection, and otherwise can be diagnosed with nuclear medicine techniques. Nuclear medicine also used for treatment of some non-infectious conditions, hyperthyroidism and thyroid cancer treated with radioactive iodine, and prostate cancer, of course, treated with brachytherapy. So at this point, nuclear medicine does not have the capability to differentiate between infection and inflammation. Both have a similar pathophysiology, infection and inflammation do. So inflammation's body's response to injury, basically. In the acute phase of inflammation, there's more hyperemia, vascular permeability, and polys predominate, whereas chronic inflammation, you have less hyperemia, more macrophage and lymphocyte predominant response. And as far as pathophysiology between infection and inflammation is the same. You get a release of histamine and serotonin, resulting in increased vascular permeability, secretion of cytokines and chemotactic factors are going to recruit cells to the area, as well as trigger complement and antibody response. And using this knowledge of the pathophysiology of infection and inflammation, we can radiolabel certain probes, white blood cells, cytokines, anti-infectives, that will be targeted to these areas. So one of the most commonly used at this point are white blood cells, or the targeting as the targeting compound, and those are usually attached with indium 111 or technetium. They have tagged other compounds with radionuclides, such as antibodies, cytokines, antimicrobial peptides. They've tagged vitamins, B12 and biotin. They've tagged antibiotics and antifungals, but at this point, those are still pretty experimental. And then the radionuclide is gonna decay and emit photons, which are going to be picked up from an external source, either the SPECT scanner or the PET scan. So gallium-67, indium, and technetium all emit a single photon as they decay. They're picked up. The different radionuclide here is the fluorodeoxyglucose. As that decays, it emits a positron, which is a double photon, and they're going to be emitted like 180 degrees from each other. So the imaging technique, tomography, is another way. The definition is imaging by sections. We know computed tomography, or CT, which is external X-rays, and then generated by a computer to form a single image. The SPECT scanner picks up the radiation in the form of gamma rays from the decay of gallium, indium, and technetium to form a tomographic image. And PET scanners pick up the decay of positrons and the double gamma rays produced by fluorodeoxyglucose. And then in the now available and probably becoming more prevalent in the near future is a combination of nuclear medicine and standard radiology, with combination of CAT scans and MRIs with nuclear imaging. So here's what a SPECT scanner and a PET scanner looks like. The SPECT scanner on the left has two gamma cameras at the top and bottom, and that's what's going to detect the photon or gamma ray being emitted from the decay of the radionuclide. And the PET scanner on the bottom, because there's a double photon emitted from the breakdown of fluorodeoxyglucose shooting off in opposite directions. It's more of a circular camera that's going to pick up that decay. So now to talk about a few of the radionuclides that are used in nuclear medicine of infectious diseases. Gallium citrate kind of acts as like ferric iron. It's injected peripherally and it's going to accumulate non-specifically at sites of inflammation, infection, or neoplasia. And it localizes to these areas by complexing with plasma transferrin, and it carries to the site of infection or inflammation. It also can be incorporated into the white blood cell and bind to the intracellular lactoferrin and be carried to the site of infection that way. And also, once it is at the site of infection, some bacteria have the ability to take up the gallium as if it was iron into the siderophore. The image in the upper left is a normal gallium scan. it's gonna accumulate in the darkened areas here. So the liver, the intestines, the spleen, the intestines again. Also, there's increased uptake in the bone marrow, so you can see it in the axial skeleton, the lacrimal glands, and the nasopharynx. These images are obtained anywhere between 18 and 72 hours after peripheral injection. The clinical indications for gallium scans include FUO. They're best in immunocompromised patients. It can diagnose opportunistic infections, uncomplicated chronic osteo, and discitis. This is just a picture of what a positive gallium scan for PCP pneumonia might look like. And then your tagged white cell scans or leukocyte scans. Remember, they're gonna be tagged with indium or technetium. And it's a two-step process. First, you take the blood from the patient, separate the leukocytes from the red cells, and then you label just the leukocytes and re-inject back into the patient. And those leukocytes will actively migrate to inflamed tissues. They've done studies where they think it pretty accurate. It doesn't the radioisotopes don't impede the migration of the white blood cells at all. Technetium today is favored for most indications, except for if you're worried about the kidney, bladder, gallbladder, or intestinal imaging, because it can accumulate in those areas. So here on your left is an indium scan, a normal indium scan with normal distribution in the liver, spleen, and bone marrow. The indium scan you inject and you acquire the scan 24 hours later. The technetium scan is a normal picture on the right, and you give normal distribution in the liver, spleen, bone marrow, GU, and colon. And that's going to be a sequential scan as well. You get 3 images at 1, 4, and 24 hours. So clinical indication for the use of indium or technetium leukocyte scans. If you have an intra-abdominal infection, you're concerned about intra-abdominal infection, you can use the indium scan is better because it's not going to accumulate in the intestines or the GU tract. Other indications: soft tissue, inflammatory bowel, FUO, chronic osteo. Technetium indications include acute osteovascular infections, fistulas, inflammatory bowel, and soft tissue infections. At this point, technetium's replaced indium as a preferred radionuclide because it has optimal radiation characteristics. It's going to decay faster and it emits more photons, so you get a clearer picture. Yes.
Explain to me once that by a nuclear medicine radiologist that technetium tends to migrate more quickly to sites of acute infection, but then it gets washed out, so it's not really good for chronic infections, whereas gallium tends to be less, sort of have a longer half-life. So for more chronic infections, if you order a technetium scan, it's likely to be negative, but if you order a gallium scan, it's likely to be positive.
That is correct. Yes. So I'll tell you about the last radionuclide, and then I have a table that summarizes them all. So the fluorodeoxyglucose is used in PET scan imaging. It's an analog of glucose. It's taken up metabolically by active leukocytes and neoplastic cells, so it doesn't differentiate. It's taken up through the GLUT1 and 3 transporters. The physiologic uptake is low, so if it does highlight, it's probably something, either infection, inflammation, or neoplasm going on. It's suitable for imaging 60 minutes after injection. It has a high negative predictive value. It's indicated for FUO, discitis, and vascular graft infections. The problem with this is the cost. Leukocyte scans are much more cost effective. So here's a summary with the advantages and disadvantages and the common uses for each of the radionuclides. I'll highlight just a few. The second column gives you the timeline when the scans are done. So the ones you can scan soonest after injection are the technetium and the fluorodeoxyglucose. I'll highlight some of the common uses. Gallium citrate these days, most commonly used for chronic infections such as discitis, is actually better than PET scan. And gallium also in immunocompromised patients because they may not have enough white cells to tag and inject back into the patient. Indium scan best again for intra-abdominal infections. Technetium for a lot of other indications that indium would also be recommended for. The problem with PET scans so far is the cost and decreased specificity. So here's our case again, 81-year-old male, AAA status post-graft and fevers for 6 weeks after travel to Africa. Anybody guess what they might want to use? Maybe more than one right answer. So probably it'd be appropriate to either do technetium, SPECT scan, or PET scan if it wasn't, if the cost wasn't a factor. So these are actual images from the case that I just presented. The CAT scan, you can see the graft there. There's not a terrible amount of inflammation there. The patient ended up getting an indium scan and a PET scan. The indium scan did light up in the area of the graft, but look how robust the response was in the PET scan. So the PET scan was more definitive or sensitive in this case. And so the patient was taken to surgery and did have confirmed staph epigraft infection. So here's some recent data looking at nuclear medicine in the workup of FUO. This is from the journal Infection in 2012. It looked at 23 patients in a row with FUO, and they ended up doing PET and indium scan on all the patients. And the indium scan was very specific and good positive predictive value, but not so sensitive and not too good negative predictive value going on. So their conclusions, based on 23 cases, the PET or the PET CT should be used as a non-invasive investigation of choice in patients with FUO. Here's another article from 2011 looking at the use of nuclear medicine in FUO. This was a case series, 7 patients in the Indian subcontinent presenting with FUO, and they did the PET scan on all these patients. Most common infectious cause they found was tuberculosis. Non-infectious diagnosis they made with the PET scan was subacute painless lymphocytic thyroiditis, sarcoidosis, lymphoma, and Still's disease. So here's another case where nuclear medicine might be beneficial. 76-year-old Asian male smoker, fever, weight loss, no travel, elevated inflammatory markers, culture workup is negative. Your pan-CT is negative, indium scan is negative. So you can think about doing a PET scan in this patient. So indium scan negative, you see the highlight area in the liver and spleen and bone marrow, which is normal. The PET scan has some uptake in the subclavicular lymph node as well as some para-aortic positivity there. And this patient ended up having tuberculosis diagnosed by transbronchial biopsy. So nuclear medicine has been looked at for diagnosis and follow-up of tuberculosis. This is from 2011 from the Nuclear Medicine journals. This is a systematic review of 16 cases looking at the use of nuclear medicine in tuberculosis, and their conclusions was that tuberculosis is gonna be PET positive, but again, it doesn't differentiate from malignancy. The PET scan and the PET CT are potentially useful in detecting sites of mycobacterial infection. They also concluded they looked at some studies, did a dual phase PET scan, and that didn't help distinguish mycobacteria from neoplastic disease. And their last conclusion was that PET scan and PET CT are useful to evaluate disease activity and response to treatment. Here's another case. Nuclear medicine might be helpful. A 63-year-old male, osteoarthritis, left knee replacement, persistent pain and swelling in that knee. He has been afebrile, just a mild leukocytosis, and elevated inflammatory markers. They tapped the joint, sterile inflammatory synovium, no crystals. And plain films showed radiolucency osteolysis and a hardware migration, which can be seen with infection, but also with aseptic loosening of the disease. So you can't get CAT scan or MRI. It's going to be too much artifact, so you might consider a nuclear image here. So here's a review article from 2012 looking at nuclear medicine and prostatic joint infections. And their conclusion was that this is sequential nuclear medicine imaging technique, where first they'll do a tagged white blood cell scan followed by bone marrow scintigraphy. So the top picture would be an example of aseptic loosening of the joint. You get a positive test in the right femur of both, and the bottom would be an example of osteomyelitis associated prostatic joint infection with a positive leukocyte scan. There's going to be inflammation and infection, but the bone marrow scan, it's abnormally functioning bone marrow, therefore it will not light up. So nuclear medicine in diabetic foot, what's the data we have here? This is a meta-analysis looking at papers having to do with diabetic foot infections in nuclear medicine. This is from 2005. So they divided the utility between forefoot and midfoot, and give a little flow chart where you might consider the use of nuclear medicine. If there's a high probability of osteo on the left side of the chart, plain x-ray is first choice, and can confirm with MRI and treat if either are positive. And they recommended you could use tagged white blood cell scan for follow-up for response to treatment. However, if the patient has low to medium probability of osteo, the nuclear medicine scans can come in more handy earlier on in that workup, especially with a negative x-ray. Then you might consider a bone scan after that, and further on down the chart. In the midfoot, they divide the flow chart in whether or not there's a associated ulcer or soft tissue infection or not. If there is an ulcer, again, they divide it by high probability and mid to low probability. You can follow the flow chart for the recommendations for nuclear imaging and your workup there. Now here's the evidence for nuclear medicine and chronic osteomyelitis. This is a systematic review from 2005. This is from the surgical literature, systematic review and meta-analysis. So looking at sensitivity and specificity of all the different nuclear medicine tests, PET scan is most sensitive and most specific. MRI is good for ruling out chronic osteo in these patients. with a high sensitivity as well. Some of these are sequential scans, the leukocyte scan followed by bone scan, which was pretty specific. The conclusions from that paper: PET scan has highest diagnostic accuracy for confirming or excluding the diagnosis of chronic osteo. The white scan has appropriate diagnostic accuracy in the appendicular skeleton if the PET scan is not available or cost prohibitive. And the PET scan is superior for detecting chronic osteo in the axial skeleton. So, in conclusion, there's a number of nuclear medicine studies out there. No single test is optimal to detect infection. Hybrid nuclear medicine is continuing to evolve, the combination of nuclear medicine and traditional radiology techniques. The currently available radiopharmaceuticals are unable to differentiate between infection and inflammation, and highly infection-specific radiopharmaceuticals are needed. So my take back from reading all these different studies and researching for this presentation, I would consider nuclear imaging for workup of fever unknown origin. Probably PET scan would be the best test there. If you have equivocal or non-diagnostic traditional radiologic testing, you consider nuclear imaging. If you're unable to get an MRI for whatever reason, if they have a pacemaker or artifacts, you can consider nuclear imaging then. And the ability to differentiate between prosthetic joint infection and aseptic loosening, you might want to consider nuclear imaging then too.